Presenters. I'm really sorry that Dr. Cristina Puentes of PAHO wasn't able to make it today. But I would like to introduce somebody that POPPHI has really enjoyed working with the SARA project and the Africa 2010 project from AED. And so we're very pleased to have Dr. Doyin Oluwole from this project. She's the director of Africa 2010, which is an AED project. And we're very happy to have her with us.
Thank you very much, Deb. Let me upfront say a big thank you to Deb and her team. It's been a great pleasure working with them. It was a very strong partnership, and I think it will continue. I also want to give credit upfront to Holly Stewart, who is the Senior Maternal and Newborn Health Advisor on Africa 2010, who provided direct technical assistance to the countries and region that I will be talking about. Today I'm going to be talking about how we used policy to inform practice. And I thought it was important, having given Africa 2010 this opportunity, to say why we were posed to doing this kind of work. The purpose for this project is to provide strategic, analytical, communications, advocacy, monitoring and evaluation technical assistance to African institutions and networks, as well as USAID regional and bilateral programs with the aim of improving the health status of Africans. And we do this through this schema. As you can see here, we provide technical assistance, we build capacity of regional institutions and networks, but we do it in partnership with other CAs and even non-USAID institutions and organizations, but with African leadership. And through our technical expertise in issues identification, solutions and best practice promotion, advocacy and communication, we change policies and programs at the regional level as well as at national level. What did we do together with Deb's group in the case of active management of the third stage of labor? The first thing we did was capacity building. And we did this through our regional institution, East Central Southern African Health Community. They, together with professional associations in Ethiopia, Tanzania, and Uganda, led the work on the AMTSL survey. I must say quickly here that the results showed about 5% of AMTSL correct utilization in Uganda to about 7.6 in Tanzania. So it was extremely low. And because of this, we went into some form of advocacy by disseminating the results not only to the countries that participated in the study, but also at regional level and international forums. Africa 2010, through USAID Africa Bureau funds, provided financial support for these stakeholder dissemination workshops, as well as presentation of results by the professional associations at different forums. Because of the success of the advocacy work, USAID East Africa jumped on the wagon, and in November 2008, they provided funding for a regional dissemination of these results, and this culminated in the development of national plans to replicate what Ethiopia, Tanzania, and Uganda had done in Kenya, Malawi, and Zambia. And this was followed very closely in February 2009 by a regional launch of the practice of AMTSL at the Health Ministers' Conference. This EXA took the lead. Together with the professional associations, they developed policy briefs, posters, all forms of communication materials to convince these policymakers as well as the technical experts that this was the right thing to do to save the lives of women. In addition to that, we provided resources through the USAID Africa Bureau funds to train journalists, because we believed that it was important to get this information out to the general public, not only to the decision makers. We've done 2 sets of trainings for journalists from East, Southern Africa, and they have carried different publications, radio, as well as television and newspaper articles on this. We have moved forward to effect regional policy reform, and this was through the EXA Health Ministers Conference that took place in February 2008, where they passed a resolution adopting the promotion of AMTSL in the entire sub-region. And as if that was not enough, it came on the table again in 2009, and another resolution was passed, this time looking beyond AMTSL to the entire attention to maternal mortality reduction in EXA sub-region. The member states, amongst other things, were urged to accelerate the institutionalization of AMTSL in at least 40% of health facilities in each of the 10 countries by 2010, and to ensure delivery by skilled attendants in 75% of women by 2012. And EXA-HC, which is the secretariat, was mandated to develop a prototype policy, national policy for AMTSL, which could be adopted and adapted by the different countries of the region. We also provided technical assistance to countries. Apart from the initial financial support and technical assistance provided to Ethiopia, Tanzania, and Uganda, we are also now providing additional resources to carry on the work at country level so that it does not stall. African leadership has been one of the strategies that we have effectively used. I've mentioned that before, with an African regional institution taking the lead, and in the countries, the professional experts and associations. And we've done all of this in partnership with the various organizations listed here. So what were the country level results? Ethiopia has advocated strongly through the Ethiopian Society of Obstetricians and Gynecologists with the Minister of Health, and they have created a favorable policy environment in support of AMTSL. Guidelines and protocols are being developed, and they are including AMTSL in all the guidelines that are being reviewed. Misoprostol is also on the National Essential Medicine list for Ethiopia. They are carrying out training, and indeed the health extension workers have now been authorized to provide oral misoprostol or egometrin, and the practice of controlled cold traction and manual removal of placenta. You all know how Ethiopia is moving on with this group of health workers. And beyond that, in order to sustain the practice of AMTSL, it is being introduced in more than 90% of mid-level health professional training institutions, and misoprostol in curriculum of 50% of training institutions. Continuing with capacity strengthening, they have included misoprostol in lower-level professional training institutions curriculum, and they are conducting cascade trainings in service nationwide. They are also revising their national health management information systems to include AMTSL use, as you heard, like other countries have done. In Tanzania, guidelines and protocols are being developed, including AMTSL, and in Uganda, they have not only taken a policy stand on adopting oxytocin as the first line for management of PPH, but they are developing guidelines and protocols that are influencing practice. And recently, they trained the OBGYN Association, trained tutors in advanced labor and risk management training, including AMTSL. What lessons did we learn in this process? Partnership, partnership, partnership. Collaboration with African leadership to solve African problems is critical for success. We need to get the professional associations on board early and leading. Regional policy reform through ministers of health and resolutions that bind a group of countries is a first key step to seeing national level action. And the media can be an important ally even in public health. They do not have to be contrary to us. What's the way forward? Africa 2010 will continue to support the harmonization of guidelines and provider updates through EXA and the professional associations. Some funds have been given to support Ethiopia, Tanzania, Uganda in the work that they're doing. And capacity building will continue in service as well as pre-service, and we're hoping that we would be able to integrate AMTSL completely into primary health care. Since that is the way that WHO is going, we would work with them and make sure that AMTSL is a part of it. We would like to see a scale-up of AMTSL in the African region through EXA, providing TA, leveraging resources from other partners on the field. We would like to document the experiences on the field and disseminate them. And in particular, we would like to learn and document the experiences of the countries that have allowed the use of Misoprostol in practice, so that we can see what their experiences are out there and share with others. And in order to keep the political commitment going, we would support EXA to provide annual feedback to the health ministers at their conferences. A similar thing we would like to replicate with the sister organization in West Africa, the West African Health Organization, to influence the 16 countries of the ECOWAS. And finally, I'd just like to acknowledge once again the partnership of all the people that are listed here, and to say thank you for addressing the health of the mothers in Africa. Thanks.
Great. And now I'd like to introduce Ann Heyer, who is actually the director of the Global Outreach Program at ACNM, but is here representing ICM, who unfortunately is having their board meeting now, so none of their leadership could really join us. So, welcome, Ann. Okay. Oh, I guess Emily has to get that.
While she's doing that, I'm going to suggest that everybody actually stand up, warm up, shake your hands. I won't make anybody do the hokey pokey, though it's quite tempting. Nearly everybody here, I think, was in 2 days of the preeclampsia meetings, and I don't know if everyone's as stiff as I am, but okay, I guess everybody can sit down. Oh, what is this? Uh-oh, there's some animation in this thing, what I wasn't aware of. Uh-oh. Okay, thanks. So I'm going to make an attempt here to represent ICM. ICM is the International Confederation of Midwives, and at this time I believe it's made up of somewhere between 90 to 100 midwifery associations around the world, and the American College of Nurse Midwives is one of the members of ICM, and given that I'm located right here in Washington, D.C., they asked if I could come and just disseminate to all of you some of the work that they did together on the POPPHI program in the areas primarily of advocacy, materials development, technical support, and dissemination. Sorry, I didn't realize when they sent this to me it had all this stuff in there. Okay. So one of the approaches that POPPHI took follows on nicely to what Doyin just said, which is the importance of really engaging the professional association. So one of the approaches I think that POPPHI utilized was to try to use both ICM as well as Figo as dissemination agents, perhaps I could say. So ICM initially started off in collaboration with Figo to undertake a review of the literature in order to inform the development of joint statements, which I'll mention in just a little while. Also, ICM undertook a survey to elicit expertise of experts about the various components of AMTSL in order to then determine what needed to go into some of these joint statements, what exactly the definitions of AMTSL would be, as well as a systematic review of literature to assess the effectiveness of physiologic management in third stage of labor at times when oxytocin is not available. So, with all of that review of the literature that they had gathered, ICM was able to work together with Figo to develop two joint statements, the active management of third stage of labor, which I think many of you are familiar with, the joint statement that is, as well as a joint statement that I believe is still in draft form. Has it been finalized on the physiologic?
I should say, I think there's an error there because the second joint statement is the joint statement on treatment of PPH or prevention of PPH in low resource settings. So I think that's an error. That's number 3.
Okay. All right. So there are 3 of them?
That's the third, physiologic.
Oh, the physiologic management, which is actually still, I believe, in a draft form. But there was a recognition, and many midwives, I think, around the world saying, well, what do we do in the situations when oxytocin or uterotonic is not available? What guidance can we provide to our members and to midwives? And in addition, there was a policy review undertaken by ICM to look at countries, or to do a policy review on countries where midwives were not allowed to prescribe oxytocin. And we're hoping, based on some of the discussions yesterday in the pre-eclampsia meeting, that because of the success of this collaboration between ICM and Figo, that there could be some additional statements developed surrounding the management of pre-eclampsia and eclampsia, perhaps together, as Peg mentioned yesterday, together with the nurses and the pediatricians as well. In the area of materials development, ICM was involved in the development of a number of the materials that Deb highlighted earlier and I think are included in the booklet, the poster on active management of third stage, CD-ROM for a more visual presentation of active management of third stage of labor, the fact sheet, as well as a review of the training materials that POPPHI developed. In terms of technical support, I think this is where ICM, and I would hope as well as when we begin to talk about preeclampsia as well, would continue to be involved in that. They are quite well placed with a large number of member associations in a large number of countries to be involved at the country level in facilitating workshops and dissemination meetings, as they did in Zambia and Benin. Workshops on active management of third stage, and I believe that there are some meetings planned coming up for Ghana, as I believe I've heard. And also in Mali as well. Okay. And then some other dissemination efforts that ICM is undertaking has really been workshops with professional associations, taking advantage of the times when the professional associations are gathering together to disseminate what the evidence says, as well as the guidance for practice as is outlined in the joint statements. So there have been a number of workshops that have been conducted, as are listed here, in Africa, the Arab countries, as planned to be conducted, coming up soon, as well as in Latin America, a meeting in Bolivia. In addition, for the ICM was also helpful in trying to include or ensuring that discussion of PPH and active management was also included in the training that's done in Sweden at Lund University, as well as in other international courses in Belgium and the Netherlands. And then ICM, every 3 years, has a very large meeting, and at the meeting in Glasgow in 2008, there was quite a bit of attention devoted to active management. Hard copy materials were disseminated, and there were panel discussions. And I have seen over the course of time that I've been involved with ICM that in many of their activities and meetings there is always some discussion of this. And so they hopefully are a mechanism by which more and more information can be disseminated to trickle down to their member associations. If you look on the ICM website, there's not a heck of a lot there, but there is a PPH thematic area with materials and links pertaining to AMTSL. So just to finish this off, in general, as I was saying, and as I have seen myself, that AMTSL is now a part of ICM's activities. Anytime workshops, lectures, presentations are included or are conducted, AMTSL does appear to be included in those. At every workshop, CD-ROMs, fact sheets, posters are shared and handed out, whether it's on the meeting is actually on postpartum hemorrhage or not. And ICM, I think, does believe that its advocacy and facilitation is going to continue over the future, both for the reduction of PPH and then moving as well, along with everyone else, I think, in the direction of preeclampsia and eclampsia as well. So if there are questions later, I would imagine that Deb, as well as our colleagues from Figo, may be able to answer them a bit better than I can. But that's just a quick overview of what it is that ICM has done within the POPPHI program.
Okay, next I'd like to introduce Dr. Rushwan Hamid, which I've always gotten it backwards, which is why I think it's like this. So sincere apologies to Rushwan. He's here as the executive director of Figo. We've been very pleased to work with him as well as a number of his colleagues. I often send little emails, a rule. What do you know about this? Can you send information on this? So it's been great to be able to work with him. So.
This is the new version.
It is. And I'm wrong. Look at this. It says it right here. Remember I told you? Yeah, you were right, huh?
Well, good afternoon. I would like at the start to thank the organizers of this meeting for the opportunity availed for me to participate and represent Figo. As you know, Figo is the International Federation of Gynecology and Obstetrics. It represents gynecologists from all over the world who are grouped in 124 societies worldwide. Usually I take this opportunity whenever the opportunity avails to profile the organization, but due to time constraints, I think we had to cut it down, this presentation, to the half the slides, isn't it?
They were very beautiful, too.
Yeah. So this is because in the last few years, the organization has had remarkable positive developments in its organizational structure. And it has got now a clear vision. Is this the right one?
What?
Okay. Okay. These are the overall goals of the organization, which aims usually for the things which we are all working for, improvement of women's health worldwide. And these are the welfare of women and newborn, improvement, raising the status of women, and upgrading the practice of obstetrics and gynecology to maintain a high standard of professionalism for gynecologists and ethical adherence. Maternal and newborn health has been a priority area for Figo for the last 10 years. And this is a commitment which we take as partners together with other health professional organizations and the international communities towards achieving the Millennium Development Goals. To achieve this, we are now involved into projects which are addressing these issues. Figo has got this Saving Mothers and Newborn Health project, which is sponsored by the Swedish SIDA. And it is a project which aims to reduce maternal and newborn mortality and morbidity and contribute to achievement of the MDGs in 10 low-resource countries in Africa, Latin America, and Asia. And the project also built to sustain the capacity of the OBGYN and midwifery societies in these countries, mainly in projects which has been identified by these countries to be their priority areas. This project is still ongoing, and you see the countries where it is being implemented. The other important project which Figo is now undertaking in maternal and newborn health is the Figo Gates Initiative, which is funded by the Bill and Melinda Gates Foundation. This has just started. We had our orientation workshop for the project in the Figo Congress in Cape Town last month. And the aim of this 5-year project is to improve the policy and practice by strengthening Figo member associations and using their position and knowledge to facilitate and contribute to these improvements. This will lead to better maternal and newborn health for the underserved populations in these countries. We will start with 8 countries in Asia and Africa, and this in the 3rd year of the project is going to be increased to 15 countries. In the area of postpartum hemorrhage, which is an integral part of our maternal and newborn health initiative, Figo, as far as 2005, its executive board has recommended to its member associations that the societies meet with their midwifery, nursing, and general medical colleagues to implement the delegation acts which will reduce maternal mortality due to PPH. And that oxytocin and misoprostol should be given in the active management of the 3rd stage of labor and delegated to nurses, midwives, and general practitioners throughout their countries. So this means that local obstetricians and gynecologists were asked also to lobby their governments to provide continuous uninterrupted drug supplies to prevent and treat PPH, as well as establish fully functional blood banks. In 2006, during the Kuala Lumpur Congress, which is the Figo Congress every 3 years, there was a Figo ICM joint statement which was addressing the area of prevention and treatment of postpartum hemorrhage. And this call of action, it starts with the call of action, which has got very important issues to address, which is to lobby the governments to ensure health care for all women. These are general issues, of course. And you can see that it has got advocacy for women to have skilled birth attendants, education with regard to association members for the need of these skilled attendants, ensure that the birth attendants have the necessary training. Also, it calls upon the national regulatory agencies and policy makers to approve misoprostol. It also incorporates recommendations from this statement into the current guidelines and competency curricula, and disseminate the statement which is following to all members throughout the available means, including publication in national newsletters and journals. So the statement has got 2 areas, prevention and treatment of PPH. In the area of prevention, of course, we have taken the AMTSL as the important area to highlight, and in that statement we have highlighted the components of AMTSL, the 3 components. Also, misoprostol was highlighted, and it shows the dose which should be administered, and also it has made the precaution that when it is administered in low settings, that controlled contraction could only be done in the presence of a skilled attendant. In the area of prevention also, in the absence of uterotonic drugs, we have got also clear sort of recommendations for the attendant, whoever, that is waiting for the signs of separation, encouraging maternal efforts, and not to recommend, of course, controlled contraction in these conditions, and uterine massage after delivery. As far as the treatment of postpartum hemorrhage is concerned, the statement does show clearly that emergency obstetric care, essentially emergency obstetric care, including the presence of IV and IM heterotonic drugs, manual removal of the placenta, and retained products of conception should be a component of the services. Of course, in the tertiary or the referral system, comprehensive emergency obstetric care should be made available with blood transfusion and surgery. And at the community level, there is the community-based emergency obstetric care should be encouraged. And Misoprostol has been advocated in this statement for the treatment of postpartum hemorrhage, and that innovative techniques which are now being introduced into systems should be like the tamponade and the anti-shock garment should also be looked into. Okay. Now the POPPHI Figo initiative, we have been an important and active partners with in the POPPHI initiative, and the Figo objective is to assist POPPHI to expand and improve the quality and availability of AMTSL at the facility level and community level through their work or Figo's work with the member associations around the world. And we have achieved quite a number of activities, as you can see in this chart. We also conducted a number of workshops in the different countries, as you can see, and a number of lectures by our members in the different congresses. The important thing which we are going to take forward, which has been developed in 2003, is the 10 key action plans for postpartum hemorrhage. And we consider these are very succinct points which can be taken further and developed by our member associations in order to implement the POPPHI activities. So I'm not going to go into this because they are available in our website, and they go over all sorts of collaborative work with other agencies regarding this issue, and the actual care and what every skilled birth attendant could do. And also it goes to the tertiary level where blood transfusion and other things should be available. Because of the constraint of time, I have to stop here. Thank you very much.
Thank you very much, Hamid. And I should say it was very hard to ask people to remove slides because there is a lot of very interesting information that they have. With that, I would like to move on. We are very excited, and he's only been able to join us early this morning, so I'm very impressed that you're here and looking quite awake. This is Dr. Michel Mpunga. He is coming here from the Democratic Republic of Congo. He is going to actually speak and has worked closely with Sushila Engelbrecht and Indira Narayawan. I never could say that very well. And this is going to be a discussion about the combined AMTSL and newborn care, the immediate postpartum care package. We are very excited to have you here. Thank you.
Merci beaucoup de m'avoir accordé la parole. Je voudrais remercier ceux qui sont à la base de ce projet ou de ce programme, que sont POPPHI et Basics. Basics actuellement commué en MSHIP, et au travers les docteurs Indira et Madame Sushila, qui sont en fait eux qui sous-tendent ce programme. Mais avant toute chose...
Thank you for your invitation. I'd like to thank the organizers and the initiators of this program, especially POPPHI and Basics, and that will turn into MCHIP, and especially Indira and others that are at the very heart of what we do.
Avant toute chose, je veux dire un mot sur ce que le projet Access. Le projet Access, c'est un projet financé par l'USAID et qui est constitué par un consortium de CRS, ECC, qui est l'Église du Christ au Congo, Vision mondiale, et IMA, qui est Interchurch Medical Assistance. Et en fait, le projet Access est plus situé dans les zones de santé de l'Est du pays.
I would like to tell you a little bit about the Access project. That is a joint project that is funded in part by USAID and also helped by CRS, ECC, WVI, and IMA, mostly in the eastern part of the country.
Le projet Access, c'est un projet d'assistance qui apporte un paquet complet aux zones de santé. Il intéresse 57 zones de santé, particulièrement à l'est du pays. Il couvre environ 8 millions d'habitants et la santé de la reproduction a une place très importante dans ce projet.
The Access Project is a full package of assistance that covers about 57 areas and covers about 8 million people, and reproductive health is at the center of this project.
Comme vous l'aurez remarqué, nous ne couvrons que 57 zones de santé sur les 515 zones que compte la République démocratique du Congo.
You'll have noticed that we only cover 57 zones out of the 515 that there are in the DRC.
Tout part en fait de la situation alarmante de la santé de la mère et du nouveau-né. La santé maternelle, selon les dernières enquêtes de 2007, montre que nous sommes à 559 pour 100 000 naissances vivantes et la mortalité néonatale qui est à 42 pour 1000 naissances vivantes. Et donc, à partir de là, le nouveau-né étant embrigadé, qui n'était pas visible, on s'est dit qu'il fallait mettre à l'avant-garde le nouveau-né. Mais comment faire le nouveau-né seul et laisser la mère? C'est ainsi que finalement, comme c'est un couple indissociable, on a voulu mettre le programme ensemble, on a voulu faire une intégration.
This all started when we noticed how alarming the situation was, the situation of both mother and newborns. And the current situation with maternal mortality is the following: 549 deaths for each 100,000 live births, and neonatal mortality 42 for every 1,000 live births. And this is what started us thinking, and we decided that we needed to bring the newborns to the front, but we could not separate them from the mothers, and this is how we decided to create an integrated program.
Le paquet de santé de la reproduction au niveau des accès comprend les soins prénatals, les accouchements assistés, les soins essentiels au nouveau-né, les soins en post-natal, le planning familial, les soins des IST, des infections sexuellement transmissibles, la réparation des fistules et la violence due au genre. Oui.
The full package for reproductive health includes antenatal care, assisted birth, care for newborn, also postnatal care, family planning, and the treatment of STIs, repairing vaginal fistulas, but also gender-based violence.
Mais quel est le paquet en ce qui concerne la santé de la mère et du nouveau-né? Il y a la CPN recentrée, c'est-à-dire la consultation prénatale, les soins au moment de l'accouchement, les soins après l'accouchement, dans les systèmes de santé, dans les structures de santé de base. Et là, le point, l'accent est mis sur la gestion active de la troisième période de l'accouchement, la GATPA. Et en ce qui concerne,
the health package for mother and newborns includes the following that you see on the screen: prenatal consultation, care at birth and after birth, as well in health establishments with an emphasis put on AMTSL.
Les soins essentiels du nouveau-né dans les niveaux, au niveau de la base a mis l'accent sur la réanimation et les traitements des infections, la prévention des infections et les traitements des infections mineures et une première dose s'il y a avant transfert s'il y a une infection majeure.
Essential care for newborns put an emphasis on resuscitation and the treatment of infections, and also the prevention of infections and the administration of the first dose if there is an infection.
Et au niveau de la communauté, on a plus insisté sur la sensibilisation des ménages à reconnaître les signes de danger avant et après l'accouchement et à reconnaître les signes de danger chez le nouveau-né et à encourager les mères à fréquenter les structures sanitaires.
At the community level, we are doing awareness with families to help them recognize dangers before and after birth and to be able to monitor the newborn babies and also to encourage pregnant women to go to health establishments.
Et tout a commencé par le traitement, l'analyse de la situation qui a même abouti à la formation, à la création d'un groupe de travail spécifique du nouveau-né. Et après, ça n'est suivi un consensus avec le leader du ministère de la Santé qui a réuni tous les partenaires pour que l'on se mette ensemble, qu'on puisse définir quel est le paquet qui devrait être intégré les soins de la mère et du nouveau-né.
We assessed the situation and we created a working group for newborn babies, and we created a consensus under the leadership of the Ministry of Health that brought together partners in order to define what the health package should include.
Ça n'est alors suivi l'acquisition de matériel de formation, l'acquisition des kits nouveau-nés pour la distribution dans les différentes structures.
We then started purchasing training equipment and putting together newborn kits.
On a adapté, produit et diffusé tout ce qu'il y a comme matériel de sensibilisation, donc les boîtes à images, les cartes conseils, les manuels de référence pour la formation, les guides pour les facilitateurs, donc tout un kit complet pour la formation.
We then started to adapt documents or materials and started disseminating them and doing awareness with cards and pictures and reference materials for the trainers and guides for the facilitators to create a comprehensive kit.
Puis il y a eu cette formation en cascade, des formations en cascade des formateurs nationaux, les formateurs provinciaux dans les 4 provinces où se trouve implanté le projet Access, dans la province du Katanga, des 2 Kasaï et du Sud Kivu. Et actuellement, nous sommes dans 43 zones de santé sur les 57 que compte le projet. Et le programme est intégré dans 218 maternités. Et on a formé 591 relais communautaires dans la promotion de la santé de la mère et du nouveau-né.
The training program was staggered. It started at the national level, but was also done in the different provinces where Access is based, the 4 provinces, Katanga and the 2 Kasais and South Kivu. We are present in 43 out of the 57 zones in which the project operates, and we also trained people at 218 maternal or birth centers, and we also have 591 community centers that we helped train.
La tendance des accouchements assistés est à la hausse, mais l'on remarque qu'il y a au niveau du trimestre 9 du projet, qu'il y a eu une baisse. C'est parce qu'il y avait un problème de grève dans certaines zones de santé. C'est ce qui explique qu'il y a une baisse, mais on est pratiquement au-delà de ce que l'on attendait. Et donc, l'assistance est en train des accouchements assistés est en train de croître.
The trend for assisted births is on the rise, except for the 9th quarter, as you can see on the graph. There was a decrease that was due to a strike in some of the health zones. But for the most part, we've exceeded our expectations, and assisted births are on the rise.
C'est la même tendance aussi avec la GATPA, l'AMTSL.
The same trend applies to AMTSL.
Quelles sont les leçons que nous avions apprises? C'est que cela allait dans le même sens du ministère de la Santé, que l'on puisse aller dans le sens d'intégrer les programmes. L'on pense aussi que c'est mieux, les fonds peuvent être partagés entre les deux domaines. Donc si le domaine de la mère, de l'enfant ont de fonds, ça peut être partagé. Et les formations, les supervisions intégrées coûtent moins de fonds, en fait, et pourraient coûter moins de temps.
What are the lessons learned? We realized that it was going along the same lines as what the Ministry of Health wanted, that is integrating programs where we can share funds for both programs for mothers and children. And integrating training and supervision for both can help us save both money and time.
Ce qui est vrai aussi, c'est que le personnel de santé a trouvé que dans la formation et avec la disponibilité de l'ocytocine, cela a entraîné à ce qu'il y ait une bonne amélioration de la couverture de l'AMTSL et la sensibilisation au niveau de la communauté, surtout avec les matrones qui amènent les femmes dans les maternités, a fait que le nombre d'accouchements assistés puisse augmenter.
It is also true that health professionals have been better trained, and also with the availability of oxytocin, it made it possible to use AMTSL more. And also awareness done at the community level helped us train the what we call matrons or traditional midwives to bring women to birthing centers, which has resulted in the increase of assisted births.
Les difficultés, c'est un processus assez long et laborieux pour trouver le consensus. Il y a un long délai pour avoir le matériel de formation. Il faut un consensus pour l'adaptation du matériel de formation et ça prend beaucoup de temps.
What are our challenges? The process is long and difficult. We need to reach a consensus, and it takes time to do so, to even get training equipment, or also to find a consensus in order to adapt the existing training equipment.
Les documents sont volumineux. Les messages à transmettre sont... il y a suffisamment assez de messages à transmettre, et donc ça fait un problème. Et s'il n'y a pas assez de personnel, il y a certains aspects, soit de la mère, soit du nouveau-né, qui peuvent être négligés.
There are a lot of documents and a lot of messages that need to be transmitted, and also if we are short on staff, some aspects of the health of both the mother and the child can be overlooked.
Nous avons encore comme challenge, le défi, c'est qu'on mette les éléments des soins intégrés, des soins essentiels du nouveau-né, de la GATPA, dans les registres de routine. C'est ça qui est encore un problème. On n'a pas encore trouvé de consensus jusque-là. C'est en cours. Les longues distances entre certaines zones et l'inaccessibilité qui demandent des fois d'aller seulement par avion pour aller faire les visites pose problème pour le niveau national d'aller faire le suivi, la supervision au niveau des structures de base. Il y a, on pense que si le niveau des zones de santé s'approprie ce programme, c'est là le soubassement, c'est là la chance pour qu'il y ait une pérennisation du programme. Et étant donné que le ministère de la Santé lui-même s'est presque déjà approprié ça. Et donc si au niveau de la zone de santé, au niveau de la base, ils s'approprient et ils savent suivre, ça pourrait être... c'est là l'enjeu, nous pensons. Je vous remercie.
The challenge is to make the elements of AMTSL and essential care part of the routine care. And this is where we need consensus, and we are having a hard time getting there. Another challenge that we face is the large distances in the DRC and the fact that some areas are only accessible by plane. So that creates challenges at the national level for monitoring and evaluation, namely. There's also hope that the health areas or the health zones will take ownership of the program, and that's a way for us to make this program more sustainable. As of now, the Ministry of Health is in charge of this program, but if the ownership can be transferred to the community level, that's where we can see sustainability.
Thank you very much. Yes, and then the last person who's going to be speaking today, I don't even need to mention his name. We all know him. He's the originator of the PPH intervention and got an award for it. Dr. Harshad Sangvi from Jupaigo. I should say while she's doing that, I don't know if anybody was around for the beginning of POPPHI and the creation of the website, but Megan Greeley has come to join us. She's now an RN and getting her FNP and MPH at Hopkins, and we're very happy to have her.
Well, thank you very much, and let me take this opportunity to really thank Debbie and her amazing team for really pushing the agenda on postpartum hemorrhage. I'm going to do a little bit of pushing myself and talk about community-based distribution of Misoprostol. Ladies and gentlemen, any of you follow the male circumcision literature and information, recognize that when the 2 male circumcision trials were being done, WHO and UN partners had already drafted a policy, had already drafted training materials, program implementation guides, and many other documents. And when the results of those things came out, it took 3 months to achieve complete guidance to countries around the world. I'm sort of disappointed that for women's health, we cannot achieve that kind of expediency. And I think we need to think a little bit about it when we have got some good results. All right, I'm going to move on to community-based distribution of Misoprostol, and I'll quickly go into the results first and then talk about the process later on because I might get cut off. Talking about Nepal, which has had a dramatic decline in maternal mortality confirmed by several studies, the intervention in Nepal was community-based distribution of Misoprostol by non-literate female community health volunteers as part of a comprehensive package of maternal and newborn care interventions, mostly education and distribution of a few commodities. For example, distribution of iron, folate, anti-worm treatment, and things like that. And a birth preparedness and a complication readiness message, and a recommendation to use the very few skilled providers that exist in Nepal. The research method was a pre- and post-intervention randomized cluster surveys with 30 households in each of these 28 clusters that were examined. There were maternal death was ascertained by systematic facility as well as community surveillance and verbal autopsies using WHO tools and routine monitoring of community care data. There's lots of information, but I'm just going to share you this piece of information. There were 18,761 pregnant women who were dispensed Misoprostol by the non-literate female community health volunteer with no significant adverse events or misuse or incorrect use. the proportion of deliveries protected by a uterotonic, that is either oxytocin or misoprostol, because our encouragement was use a skilled provider if it's possible, use misoprostol as plan B if you don't have a skilled provider, rose from 10% in that area to 72% when we added misoprostol to the mix. The largest gains are among the poor, the illiterate, and those living in really remote areas. In other words, the most marginalized and the ones most likely to suffer from consequences of postpartum hemorrhage. In the same period of time, because we encourage institutional births, institutional deliveries rose from 9.6%, 9.9% to 16%. And maternal mortality ratio among the 13,969 misoprostol users was 72 per 100,000, significantly lower than among non-users and as well as the national average that is there for Nepal. Let me then move on to Afghanistan. Community-based distribution of misoprostol in exactly the same intervention, a community-based distribution of misoprostol by non-literate community health workers as part of a basic healthcare package. We used a variety of methods. These were completely non-literate, so we were using records that were completely pictorial, postpartum interviews, and mortality reviews as well as focus groups. Results, 1,970 women were dispensed misoprostol by non-literate community health volunteers with no significant adverse effects, misuse, or incorrect use. We obtained near universal uterotonic coverage, 96% in intervention areas compared to 25% in control areas where we had not introduced misoprostol. The uterotonic in those other areas was oxytocin with skilled providers. The CHW were willing to do this work as volunteers, and District Shura, the elders in the district, were found very many ways to reward these volunteers for their work. In the control districts, we found something very unexpected, which was women were more likely to use traditional medications such as opium extracts to stop bleeding, and this resulted in many other adverse events that we had not even expected. So, what do these interventions mean? First of all, the intervention is about community volunteers identifying all pregnant women in the catchment area. That in itself is a very useful intervention. The second part is that they have detailed discussions with not only the woman, but her entire support team, her husband, her mother-in-law, her mother, her sister, anybody who is there. So they are all provided information about postpartum hemorrhage and what to do. And it's a discussion. And finally, they are given information about misoprostol, the safe and correct timing of the use of misoprostol. The misoprostol is distributed at 8 months, the risk of taking the tablets prior to birth, the common side effects, and where to go if postpartum hemorrhage occurs anyway. So all that information is provided. And the drug is only distributed to them if not only the woman herself, but her support people can repeat the information correctly. Otherwise, they are re-educated. And in the follow-up, as a part of services, there is a follow-up visit done by the same community volunteers, and they discuss the birth outcome. They ascertain whether the timing of the misoprostol use was correct. They inquire about perception of blood loss, side effects and complications, and need for any treatment that they received. So this was a system that was established. Both these governments have made a decision to scale up these interventions, and in Afghanistan we'll be moving to another 6 provinces, and in Nepal in about 4 or 5 provinces in the next year. But there are questions. So these are the type of questions that come to us. Doesn't this program inadvertently decrease skilled attendance? Isn't this against the global strategy of skilled attendance and facility birth? Isn't this part of a in the meantime argument? Does this make misoprostol available for misuse? For example, abortion. And won't women take it incorrectly and have even more mortality? Let me skip that one. This is data from, because that's already been discussed, but this is data from our older study, the first study in Indonesia, and we clearly showed, as we did in Nepal and in Afghanistan, that the proportion of births in these intervention areas actually increased with skilled providers. So the message was getting to people. So we are not going to decrease skilled attendance just because women have plan B. This is data from about correct use of misoprostol. And let me just take the Nepal data because that is the largest data that we have. We provided in counseling and the medication, that is misoprostol, to 18,000 women. 13,900 women actually took the medicine, and we retrieved every medication package that was not used during the postpartum visit. There was one woman in Nepal who took the medication at the wrong time. This was a woman who had a major fight with her husband and decided to take medications. She took her husband's hypertension pills, other pills that were there, including the 3 tablets of misoprostol. So that is considered, we consider that very seriously. The woman, fortunately, reported the incident to the female volunteer who took her to the hospital. She gave birth normally 3 days later at 36 weeks, and the baby and mother are okay. We haven't sorted out that domestic problem yet, though. There are lots of mortality data that I can say, but these are not from other studies. In every one of these areas, I think there has been concern that using of misoprostol is going to increase mortality. Actually, it doesn't in our surveillance in every one of these countries. And we do really fine surveillance, particularly in Nepal. So my take-home message here is community-based distribution for misoprostol is safe, acceptable, feasible, and programmatically effective. I think that universal coverage for uterotonic protection against postpartum hemorrhage is possible if we are willing to trust and educate and support non-literate community volunteers. And my own belief is that the one person who should hold the misoprostol should be the woman herself, because she will be always present at birth, and she is the least likely to misuse the drug. I think that when we discuss all of these things, we need to discuss the limitations of these types of interventions together with the potential benefits. That's how we made the decision for community-based distribution of oral contraceptives. That's how we made the decision to do intermittent preventive treatment of malaria at the community level. We made many such decisions. We need to make those same decisions right now. Thank you very much.
Why don't you all come back up to the podium, I suppose? Wonderful set of presentations, and a very big thank you to everyone. I think we'll take some questions. Anne.
I'm Anne Blank from the Maternal Health Task Force at Engender Health. I have a question for Harshad. I noticed, it was very striking to me in your data from Nepal, that somewhere around 19,000 women were given misoprostol tablets, but only about 14,000 of them actually took the tablets. And it made me start thinking about cost and cost effectiveness. And I haven't really seen much, if any, data on the cost effectiveness of community-based distribution of misoprostol. I just want to know if you can comment on that.
Thank you. That's a great question. I think, let me just say that our approach was not to let the woman, the woman had 2 choices. If she managed to get to a skill provider, or a skill provider managed to get her, then the skill provider made a decision of what they wanted to use. So in many of those other women, they got oxytocin and active management of 3rd stage. There were a small number of women who did not have a skill provider and chose not to use it, either because they forgot, and that's a very small number, either they forgot or their helpers did not remind them to take it at that time, or they had gotten that medicine somewhere else. We also retrieved all of the drugs. Now, we don't reuse retrieved drugs, but the intention of retrieving those unused drugs was to make sure that there wasn't a lot of misoprostol lying around in the community. I think the question that you have is cost effectiveness. In all honesty, if you've got a nation which has got 20 to 25% coverage at maximum with the uterotonic agent, and we can increase it to 70, 80, 90% using this thing, then I think we are going to have significant savings from the postpartum hemorrhage that we have. We haven't done any cost effectiveness, especially with misoprostol, but certainly with active management, there are 2 or 3 other cost effectiveness studies that actually show that there is a cost savings overall.
Thank you. Yes, sir.
Thank you. My name is Yusuf Tawfiq from URC. My question is the presentation from Figo, please. I think you mentioned in the conclusion the importance of having comprehensive obstetric care, and I think I agree completely. I was wondering what are your comments about the quality of the emergency obstetric care in the countries you are working in, and what would it take to improve the effectiveness of emergency obstetric care where things really go wrong with the delivery and there's a need to blood transfusion and cesarean section and so on. Thank you.
Well, thank you for the question. I think this is a question which will be different to answer, especially dealing with the different countries. And each country has got its own situation. But in the countries where we are working, definitely essential obstetric care has been identified as one of the areas where a lot of improvement needs to be made. And it is not an easy system because there are countries where reaching the facilities itself from the community level is quite difficult. And to avail this emergency obstetric care in these countries is really a problem. You have the problem of the roads, you have the problem of the health service providers, you have the problem of the facilities itself where they can get into the transportation. So I think it can't be answered in general. Each country has got its own specific needs, and it is one of the challenges. It has to be taken in the context of the health system infrastructure of that country, and it takes, of course, in consideration also the economic and socio-cultural implications in that particular country. Thank you.
Great, thanks. Any other questions? Stacy.
Thank you all, and in particular Harshad. I just want to support one of the things that Harshad talked about, which is the idea that more women will deliver at home if they have access to misoprostol. We found, what you found in Ghana is that the rate of delivery at skilled facilities actually went up because you're creating community awareness, you're educating about PPH, and we also encouraged the TBAs to come with the women so the women felt more comfortable, so everybody was happy. And Harshad, I know you'll publish this data, right? And get the word out there.
Right. Actually, this has already been submitted and is scheduled to be published in early 2010. But if I can just add something else to what you just said, I think there is no doubt that we need to promote skill care at birth, and we should do that. But I think it's sort of very difficult in a community to go and tell a community person, go and identify a skilled provider. If there isn't a skilled provider nearby or within 50 miles or so for her to find out, I think we cannot give unrealistic advice in communities. And I think we stand ourselves to be ridiculed if we are going to provide advice of that kind. So I think our intention has always been in our educational messages to promote the skilled provider, because the skilled provider has many other things that they can do for the pregnant woman. But there are challenging environments where skilled providers are very, very few. Many countries in Africa have very, very limited number of skilled providers, and health facilities are very, very far away. So I think a Plan B approach makes sense to me.
I have a question to Harshad. After Matthew's presentation and after one of our learned audience asked about somewhere misoprostol is being stopped and somewhere it is being used, so what is your final comment regarding the use of misoprostol?
There is no final comment from Harshad. No.
I think that countries have to make decisions for themselves depending on the circumstances the countries are. Today, there is good acceptance that misoprostol, and WHO in its guidelines says that a trained health worker can give misoprostol if you do not have oxytocin available. I think countries have to make a decision about what training is sufficient and how what they define as their health workers who can actually use it. That is a country-specific decision that countries have to make. But as I said earlier, I think till such time as the global guidance comes from WHO and other organizations, what we should be doing is continuing to do additional data monitoring, controlled introductions, so that we do build the evidence base. I think it's important to monitor the situation. Nobody wants to create a situation of adverse outcomes. But I think, as I said earlier, let us look at adverse outcomes of these potential with the potential benefits that we can get.
Wonderful. Yes, sir. Professor Hussain.
I have a very small point. There were one pilot project is running by the ICDDRB in Dhaka that they are giving 400 milligram of misoprostol. Do you advocate it? Very simple.
Yeah, I think dosing studies are actually extremely more difficult to do. And again, dosing studies, let's look at our history with oral contraceptives. You know, it took us almost 15 years to move from 50 micrograms to 20 or 30 micrograms. They took a long time. They were not necessarily randomized controlled trials, by the way. They eventually depended on wide-scale utilization. I have a feeling, and Justice Hofmeyr, who has studied this quite a lot, seems to think that 400 micrograms will be the dose that eventually we will all be using. But there isn't those randomized controlled trials today to necessarily justify the lower dosage. 600 micrograms does give women a significant amount of shivering, nausea, even fever. These are side effects to expect. And what we've learned is if we alert women about the side effects ahead of time and we advise them on how to cope with the side effects, then they do very well. Acceptability is very good. They are willing to recommend it to their friends and use it in the next pregnancy.
Okay, I have a feeling people are ready to head for a break. I would like, hold on. I had a request from Carmen, our Peruvian champion. She wants everybody who's a midwife to raise their hand. So who's here that's a midwife? Oh, there's more of us than I thought. Oh, good for you, Harshad. I thought so. Okay, she would like to see everyone at the reception. So I just want to put that out there. Ellen will be happy with me that I managed to remember. Sarah.
One more thing. If you ordered materials prior to the meeting, please be sure to pick them up at the table.
Okay, and I'm going to say 10-minute break so that we have you back here in 15.